is doing a lot of good work there in resource restrained settings, and he's also a member of our Global Neurosurgery Committee. Surath, please.
Thank you very much, Professor Tariq Khan and the organizing committee for the opportunity. So today the topic is innovative approaches in neurosurgery under difficult circumstances or resource-constrained circumstances. So wherever you work, whether it's a resource-splendid environment or a resource-constrained environment, our vision is mainly patient safety and the best long-term outcome. But when we work under resource-constrained environment, especially we need to maximally utilize whatever the available resources. So in that case, we need to innovate most of the time. So as a neurosurgeon who had been working under difficult circumstances in the peripheries of Sri Lanka for the last 8-9 years, although I'm in the center now, so this is the day-to-day struggle. So most of the time we end up in frustration. So you have the vision, you have the skills, you have the incentives, action plan. Unfortunately, you don't have the resources, you don't have the infrastructure. So you end up in frustration. To avoid frustration, so I think most of the time you need to innovate. So you need to think about alternatives. So this is the daily struggle for us, right? Most of the LMICs, so they do have these drawbacks, lack of ICUs, HDU facilities. Most of the time, you don't have the theater facilities round the clock, and lack of manpower, and lack of surgical instruments, etc., etc. So you name it, most of the time we don't have it. And also you have to fight with the public misbelief, ignorance, and also high volume of patients is also a headache. So what you need to do to bridge the gap, you need to have a thorough knowledge in your anatomy. You must be a skilled and a safe surgeon with a good attitude and always look for the safe and effective alternatives. So these were the drawbacks I have had, and these are the innovations and alternatives I came up with. So we did not have GA facilities round the clock. So we used to operate under local anesthesia whenever it's possible. And lack of ICU facilities, again, I operate under local anesthesia whenever it's possible. So I had a very low threshold for tracheostomy even at the time of surgery, and I practiced keyhole approaches under local anesthesia. So most of the times we did not have MRI or delay, so we operated without the MRI and even with the CECT. Lack of hardware, we use most of the times autographs as much as possible, and for example, fibular grafts and pericranium for the dural repair. So no navigator, I used craniometric points, no endoscope, no problem. I used keyhole microscopic approaches. And most of the time you trust on your skill and acumen rather than the technology. So within the next few slides, I'll show you a few scenarios and how I innovated and used the alternatives. So scenario one is hypertensive ICH. You can see 50% mortality in most of our settings because of these reasons. So what I try to do, I used a keyhole most of the time under local anesthesia or sedation with a very small mini craniotomy to evacuate the ICS. So this is how our patients die, even though we do an EBD or tracheostomy, it's not going to work, right? So this is what we did. You can see this is the pre-op CT, the large ICH with the pre-op GCS6. So this is the keyhole I used. So this is the post-op CT on the right side. You can see it's a very small frontal keyhole, very small burr hole, and this is the post-op. And this is post-op after 9 weeks. So you can see this is the incision I have made. It's a very small incision. So if you don't have GA, you can do it under sedation or even under local anesthesia. I can show you so many examples. You can see this is the opening. So you can use either temporal approach or the frontal approach. Temporal approach is not that difficult, right? So I'm not going into details of the technique because of the interest of time. So this is through the frontal burr, you can see. But this is a little bit challenging. You have to have a lot of practice to go through the frontal burr, especially under local anesthesia when the patient is struggling. So I can show you so many examples. See this is the post-op. So this is the burr hole. This is so many examples I can show you. So most of the people being saved with this approach, right? I have done under general anesthesia, sedation, local anesthesia, even IVH. I have gone through this occipital burr hole and I have inserted the EVD. So I'll just quickly go through this and I will fast forward it. So this is done under local anesthesia. This is through the frontal approach. So you can see it's a very you make the burr hole and you make it a little a smaller mini craniotomy. You can call it a keyhole, and then you have. Especially, I have done all these cases without the navigator, so you must be spot on with your craniometric points because if the entry point is wrong, I think the whole procedure is you will be in very great difficulty. So you have to be spot on with your craniometric points, especially if you don't have the navigator. But I have operated all these cases without the navigator. So this is how you take the clot out, and you have to be patient. You don't do any collateral damage, minimal diathermy. So in the interest of time, I will skip. So hemostasis is very important, 10-15 minutes, and then you close. And this is so I have done 373 cases over the last 5 years with a 30-day mortality of 12.5, with a 6 months mortality 60%. Right. So another case. So these scenarios, thick SH with low GCS. So most of the time, patient present with a low GCS, and especially old people, they die even before we do the CT angiogram, because most of the time we don't have the ICU facilities. So in that case, what we do a dominant side decompressive craniectomy until we buy time for the CT angiogram. So see another patient with the AVM, but this is the CT angiogram that we all get. You know, we don't get much of the anatomical information from this, but you have to go with your clinical acumen and the anatomical knowledge in these type of cases. Right. Another scenario. Doing glioma surgeries and even meningiomas under local anesthesia under selected circumstances. So we don't have brain mapping. We don't have neuromonitoring. Did not have neuromonitoring for the last 7-8 years. So this is what we do. We do it under total local anesthesia. We do it under scalp block. So this is the pre-op and the post-op. So the complete surgery, the whole surgery is being done under local anesthesia with communicating with the patient throughout the surgery. So all these cases done under local anesthesia. So you can see the patient is buttoning his shirt after the end of the surgery. Again, the dominant hemisphere. So language pathways are involved. So we operate under local anesthesia, communicating with the patient throughout the procedure. So I'll skip in the interest of time. See, the lung is bad. Anesthetist is not willing to anesthetize. So you want to anesthesia. Right. So again, see, this is a Cavanova done the local anesthesia, but in the interest of time, I will skip this. So minimal, again, keyhole access, keyhole removal of meningioma, excision of meningiomas. And so most of the time you need to operate without the MRI, because the MRI facilities are not available. So we did it under contrast with the contrast CTs only. So even with the contrast, it is not available because patients come with a very bad, very bad, in a very bad stage with low GCS, had create without contrast CT even. So last scenario, cystinostomy. I used to do cystinostomy. This is my first case of cystinostomy. I started cystinostomy to reduce the rates of cranioplasty. This is my first cystinostomy case, an 18-year-old lady with a GCS of 3. This is the pre-op and this is the post-op. So we were able to put the bone flap on the day 25, ultra early. So this is discharge on day 27. So then I did so many cases of cystinostomy over the last 4 years, 217 cases, and marked reduction in the number of cranioplasty to 27%. So,
Thank you, Surath.
and the outcome was that good. Yes. So I'll be finishing again. So fibula as a graft material, and in the interest of time, I'll conclude. So in conclusion, you need to have a thorough knowledge in anatomy and function, especially when you are working under difficult circumstances, and you have to be skilled, safe, and look for safe and effective alternatives without violating the principles. Thank you very much.
Right. Thank you very much, Dr. MUNASINGH, for presenting a wide array of management of cases in a low resource setting. Now we'd like to hand the floor back to our keynote speaker, Dr. Ernest Bethelmy, and he'll be joined by Dr. Hamisi Shibani from Tanzania. So Dr. Shibani is the head of pediatric neurosurgery in his department and also the assistant program director of the College of Surgeons of East Central and Southern Africa and member of the WFNS Global Neurosurgery Forum and Neurotrauma Committee as well.
Thank you very much. Very nice to hear very good presentations. And now the AI being introduced in the discussion. Just to hint on our colleagues, I have this question. With the collaborations, international collaborations, it has been mentioned as the most key important aspect in developing global research and global neurosurgery. How do they find this scenario? You know, a giant collaborating with the very small creature. How is the relationship? Are we now sensitizing things like colonization, or how do you tackle this issue? If I ask this question to Ernest and Sega.
Yeah. Thank you very much. I won't say too much because I want to hear Sega's response as well, because he has lived the experience and perhaps can share with us both from the clinical capacity development and research capacity development standpoint. I will disclose that Sega and I do partner around research.
Yeah. Thank you very much. Yeah.
Thank
It's a very important question, and I think our training program has been established with like a collaborative effort, and even though it was started in 2008, it has been like the process has taken like 4 or 5 years of back and forth correspondence and also fact finding and so on. And the major principle when the training program was opened was like to have a self-sustainable program. So that was one of the things that is really valuable, I think, because training of trainers was the most critical part that I found useful, because at the end of the day, we have a very good support from our collaborations, but at the end of the day, it has become sustainable. And when you see also the research collaborations, I think I found that we have been more and more being self-sustainable. I think I assume because the number of co-authors and so on has been like more from within, so that was enabling. So the collaborations were really enabling, and we value the collaborations. But yeah, that's our experience.
I want to jump in. There's a question in the chat regarding Surath's presentation, which was very, very nice. And I think many people from the lower and middle income countries can relate to it, regarding not having the facilities but still being able to do precision surgery. So when I came back to Pakistan in 1990 after training in Belfast, we had nothing here, definitely no neuro navigation stuff, even that wasn't there anyway. But we were taught very good anatomy. And even today, I joke with my younger colleagues who cannot do anything without neuronavigation, that if you are very clear about your anatomy, you can hit the lesion freehand as well. Obviously, having the technology makes a very big difference. Obviously, having MRI scan, obviously having CT angiogram, obviously it makes life very easy and of course much safer for the patients. But if you do not have that facilities, that does not mean that you should not be going ahead and doing patient saving operations. So I think that's one point which I must try to add on that. And also, Ernest, my question to you is regarding a very important part of global neurosurgery, which you must, and you are a champion of that, is talking about decolonization of neurosurgery. Maybe you want to say a few words on that, which were just now pointed out to me by a message from Luis Barba as well, that you need to leave stuff there, and training is most important to do that. Ernest.
Thank you, Tariq. So I'll try to be brief. I think about this a lot. I think just to nod to him, to Shabani's initial comments. History has left us with the disparities that we're dealing with globally. And mitigating the disparities that have resulted requires us to understand that history, and often we don't understand it as well as we could or should. I borrow from Paul Farmer's reflection that it's very similar to our patients who we treat in medicine, who we need to take time to whose history we need to take time to understand. We need to know the history of the present illness. Oftentimes, we've heard it said that 90%, 95% of the treatment pathway, the cure, is actually in getting a good history. And I feel that a lot of decolonization is about this, acknowledging and recognizing how we got here, how we got to these major disparities. And I think the better we understand that, the more naturally the solutions to those disparities will tend to develop. I'll finish by saying, in my own practice with partners, I recognize an inherent imbalance coming from the United States. My parents are from a very poor country. Both of my parents are from Haiti, but I grew up in a very wealthy country, which sort of introduces its a whole other slew of factors. But even when I go back to my quote unquote home country, I recognize my position as sort of a foreigner, a mixed foreigner, but someone who comes from a very different experience. And it takes a lot of extra steps to think about, why should I be the first author on, ABC or XYZ project? Or where am I sort of assuming that I know better when in fact, I may be quite ignorant? And I think the process of decolonization requires that kind of sometimes very difficult self-reflection and awareness. I think when you do that, the work happens in a very different way. And so that's why the conversations about decolonization need to multiply and expand. And I think a lot of it will be about recognizing how history has left us with legacies right now that are affecting all of the disparities we see in global neurosurgical disease and care.
Thank you. I would like to add here that the global neurosurgery community has grown a lot. We had our first meeting in Peshawar, the global neurosurgery meeting. It was amazing. And since then, we have been having regular meetings. And because of those meetings, we have developed a champions group for all those who are interested. That champions group has been working in different countries to improve neurosurgical care, or in countries where there is no neurosurgery. And two very important examples in the last 5 years. Number one is Afghanistan, where we have been able to get the neurosurgeons together. They have Professor Ali Aziz Sultan from the United States has developed a great Wi-Fi setup for them, and they were able to do their first neurotrauma webinar a few months back. And the second very important one is Sierra Leone, which had no neurosurgeons. And today there's one neurosurgeon working there, already done shunts and chronic subdurals. And they were trained in Rabat. And the second one is being trained in Rabat. They were initially helped through donations, and then Mission Brain, one of the organizations which partnered with Global Neurosurgery Committee, did that, and were able to work with them. And now we will have the other neurosurgeon in the next 2 years as well. And now they're working on South Sudan, Sega and other people know that, and also in Gambia. Samisi, please.
Yeah, thank you very much, Dr. Tariq. And actually, the second WFNS Global Neurosurgery course and conference will be in Dar es Salaam. Just to show that we are not colonizing, we are decolonizing. So it's moving. So I invite all of you to Dar es Salaam in April next year for Global Neurosurgery.
Thank you. So I would like to